Diagnostic criteria for depression is decreased mood and or loss of interest in activities that previously made the person happy, and 3 to 4 of the following: feelings of worthlessness or excessive guilt, insomnia or hyperinsomnia, fatigue or loss of energy, decreased ability to think or concentrate, substantial changes in weight, psychomotor agitation or slowing, and recurrent thoughts of death or suicide. So I typically start with the PHQ-2, which is little interest and pleasure in things you used to enjoy, one day of the week, all the days of the week, or half the days of the week. And then feeling down, depressed, hopeless, one day of the week, half the days of the week, all the days of the week. So typically for me, if the PHQ-2 is positive, then I'll reflex into the PHQ-9, which goes through all of those that we just discussed. So the next step in assessing for depression in the primary care setting is actually assessing for suicide risk. And you need to discern if there's a plan or someone has a prior plan. The risk factors I want you to focus on is male, the age group of those greater than 65, and those who have a pretty prominent family history of family members also having depression and family members having suicidal thoughts. Treatment is synergistic with both therapy and medical management. The first line agents are the SSRIs, or selective serotonin reuptake inhibitors. These have pretty much the same side effect profile. They all kind of cause GI disturbances and some sexual side effects. Fluoxetine has the longest half life, so if you titrate off or titrate down, it's going to require a longer washout. Paroxetine has the largest sexual side effects, and watch out for QT prolongation with citalopram. SNRIs, or selective norepinephrine reuptake inhibitors, have fewer GI side effects, but they do have a risk of hypertension. These include like venlafaxine, or you may have heard of duloxetine in the SNRI category as well. Other agents you can try include bupropion, although you want to monitor for lowering seizure thresholds with this medication, and then mirtazapine, you may have seen that as well. That can be sedating, and there is a risk of agranulocytosis with that. TCAs are typically second line now, and they should really be avoided in all cardiac populations. And then, as always, you always want to start low and slow dosing for patients that have depression. So now that we've gone through assessing for depression, whether or not the patient has suicide risk, we've gone through treatment, now we need to see if they actually have a response, right? So the treatment can actually take as little as 3 to 4 weeks, or it can take as long as 6 to 8 weeks. If they have gone 8 weeks with no response, you typically at that point want to transition to another class of medication and or add counseling and therapy on top of the medical treatment. Now, in terms of discontinuing treatment, treatment is variable for everyone. Some people can come off treatment in 6 or 9 months. Some people need to stay on it much longer. Remission is defined as 3 weeks without depression, or like without depressed mood or anhedonia. And then once the patient is ready to discontinue, you want to slowly taper that off. And that could be, 1 to 2 months of a taper. And you want to monitor for like rebound or like worsening depression or worsening like thoughts. Okay. So that's pretty much it today for depression, guys. Like and subscribe this video if you want to see more videos like this. And thank you so much for your time.